Okay, so David Clark is going to be talking about improving access to psychological therapies, science, politics, economics, and practice. I'm not going to say a great deal about David. There is a great deal to say, but I am going to say that David is the consummate applied psychologist, as I think you all know, marked by the fact that he's both made a huge theoretical impact to the science of clinical psychology and indeed psychology more broadly, but also the social impact in terms of what he's going to talk about today, which is IAPT, which is a momentous and really game-changing thing, which he and others, but David as a psychologist driven it, have essentially generated and continued and made successful. So David, over to you.
Great. Thank you very much, Paul, for those very kind remarks. So what I'm going to do is talk a bit about the Improving Access to Psychological Therapies, or IAPT program. I notice actually it is something that I gave a department seminar on a couple of years ago. So some of you will have heard that, and to say there's plenty of new stuff in it. And for those of you who didn't hear it, it's coming again in a slightly different form. I was asked to say a little bit about my background and how I ended up where I am. Just to save time, I should say there is a short interview with me on the In Conversation with EP staff section of our website, which explains that I'm a northern boy who was the first person to take A-levels, never mind go to university in my family. And I was very lucky to end up in Oxford as an undergraduate, actually for chemistry, and even luckier to then switch to psychology. So I'd like to start off with a good news story and a problem. So the good news is that research over the last few decades has led to really substantial advances in the development of effective psychological therapies for common mental health problems. So much so that now the government agency that's charged with summarising the evidence for interventions that could be deployed in the NHS, that's NICE, recommends evidence-based short-term psychological therapies, so between 14 and 20 sessions, as the first-line interventions for common mental health problems such as depression and all the anxiety-related conditions, including post-traumatic stress disorder. So that's good news. Also, it turns out that that's a recommendation that's popular. So there have been many surveys which have asked people, if you had a choice between medication, which has evidence for it, or an evidence-based psychological therapy, what would be your preference? And of course, some people say, well, I'd very much like the medication. But consistently, in a ratio of about 3 to 1, people say, I would prefer the psychological therapy if I can have it. But back in 2007, before the IAPT program started, the situation in the UK was really bad. Less than 5% of adults with anxiety or depression in the community were being offered an evidence-based psychological therapy. Somewhat more were having some psychological interventions, but they weren't the evidence-based ones, which would be CBT in anxiety disorders, or several interventions, CBT, but also interpersonal therapy, a form of counseling, and psychodynamic therapy in depression. And the waits to have those treatments were often over a year. And we weren't unique. There was no country in the world where the public was getting what it wanted in terms of mental health interventions. So the IAPT program is an attempt to move towards a solution to that problem. And it aims to do it by training a large number, currently 9,800 psychological therapies, to deliver NICE recommended treatments using a national training curriculum. Everyone gets trained in the same curriculum, and you only pass the courses if you demonstrate competence in delivering the therapies in real life with videos of your therapy sessions. And then to deploy those newly trained therapists in stepped care services for depression and anxiety, NICE had pointed out that for many of the more mild to moderate cases of depression or anxiety, a lot of people benefit from what we call low intensity interventions, ones which don't involve a lot of therapist time because they're based on sort of self-help principles such as guided self-help, computerized CBT and things. But for people with more severe depression or anxiety, and for those who have not benefited from the low intensity interventions, then more conventional once a week face-to-face therapy is recommended. And so the step care model implements both. And the key feature of the program was also to do something which was radical at the time, which is aimed to measure and publicly report the outcomes of all the patients who are seen in every single service. A unique exercise in public transparency. And the initiative was based on sound clinical arguments, of course, NICE had summarized them already, but also sound economic arguments. And so a lot of the lobbying from it was a coalition between a very distinguished economist, Lord Layard, from the London School of Economics, and myself. So what were the sort of key IAPT arguments? Well, if you want to see them in detail, you can see them in the book that Richard Layard and I wrote called Thrive, The Power of Psychological Therapies. But broadly speaking, the first point was to point out the immense cost of not treating anxiety and depression. And it is an enormous cost, because untreated anxiety and depression depresses the gross domestic product of the nation by about 4 percentage points. Even in COVID terms, that's an awful lot of money. And that's partly to do with absenteeism, people not being able to work because of their mental health difficulties, and therefore reduction in tax revenues and less productivity. But also when people are at work, their mind is often elsewhere on their worries, and that means they're less productive. That's what we call presenteeism, and it costs companies a lot of money. The second point was to point out that if we did increase access to psychological therapies, evidence-based ones, and we're able to achieve the sort of outcomes that you get in the research literature, then that program would actually have a minimal net cost. And that's because assuming we can get the right outcomes, then the savings to both the NHS and the Treasury would each exceed the cost of an average of 10 sessions of therapy per patient. Often people who are anxious or depressed have much increased other healthcare costs in the NHS, physical healthcare costs, and that's where those savings would come from. And then lastly, there was already some evidence, and you'll see it came from Northern Ireland, that we can train therapists in routine services to deliver treatments effectively at the level of the outcomes you get from NICE recommended interventions, the trials behind them, and also that it is actually possible to monitor the outcomes of everyone in a service in order to really check out whether it's working in practice. So that was the background. It started the national rollout in 2008. So where have we got to so far? I put it up to just before Christmas, but the picture hasn't changed much since then. Well, so IAPT started small and saw about 180,000 people in the first year. That's now risen to over 1 million people accessing the services every year. The services have two roles. One is a sort of assessment and triage role where people with a range of mental health problems come in and get a good assessment. For some people, of course, it turns out that anxiety or depression isn't the key problem and they can be referred elsewhere. For some people, actually, it might be more debt counseling or some other sort of social assistance that's more important for them. But round about 640,000 people each year have anxiety and depression, which would warrant a course of psychological treatment, and they're offered that. The waiting times have plummeted from the over a year pre-IAPT to now an average of 20 days. And the services have been able to collect outcome data on 99% of that 640,000 people each year who have a course of treatment. So when you've got a complete data set, you can, of course, look at what are the outcomes. And currently they are broadly in line with what you'd expect from the research studies that underpin NICE guidance. So we are getting roughly the sort of outcomes you'd see from the research studies. And this is really shown on the graph here. So at the start of the program, I told the minister who announced it that if we did things well and trained everyone well and deployed them in an optimal way in the services, we should be able to get 50% of people to be fully recovered from both anxiety and depression, a rather stringent criterion, and round about 7 in every 10 showing worthwhile improvement. And you can see that is where we are now. Over 50% of people are fully recovering, and round about 7 in every 10 are showing substantial improvement. And we've been in that position for 5 or 6 years now. But you can see at the start of the program, we were well below that expectation. And it took quite some time to get to the level that we are now. And really getting there has been possible because of the data that's been collected and learning from that data. And I'll go on to talk a little bit about that in a moment. But you can see from the quotes, this is a program that, although it's an English program, has attracted considerable attention internationally. Nature, in an editorial, kindly described it as world-beating. And the Canadians recently, when they've been considering improving their mental health system, had a report which was simply headed, "For better mental health care in Canada, look to Britain." So the outcomes in terms of symptom reductions are good. What about a more general issue to do with patient satisfaction? Well, the IAPT system also collects that data, although it's less complete than the symptom data, but the data that we have looks very encouraging. So most people seem to have been satisfied with their assessment. They felt that the staff listened to them and took their concerns seriously, and they felt that they got the help that mattered to them. And from studying variation in outcomes between different services, we've learned an enormous amount, and that information has been fed back into the system, and we've been using it to try and bring all services up to a good level. If you want to read about all of the sort of learning, you can download the IAPT manual from the NHS England website. Here on the right, I've shown that sort of process of learning and how it's affected outcomes. So this is the sort of recovery rates for the nation each year between 2015 and 2019. So the dotted line is the overall average figure for the country. You can see at 2015, there was quite a lot of variation, so that we have some services as the top 10% of performers that were having recovery rates nearer 55%. And then the bottom 10% of performers, it was more like 35%. So a lot of regional variation. But understanding the determinants of that and feeding it back meant that we'd halved that regional variation 4 years later, largely because we've taken the poor performers and helped bring them up to a closer level of the top performers. So what have been some of the lessons that we've learned from the outcome data? There are an enormous number, and in the time available for this talk, I can't take you through them all, but I'd like to highlight a few key points. The first is the importance of providing people with the treatment that NICE recommends. Many psychotherapists, including myself, feel that our individualized assessments are very important, and we may have good hunches about the way to go in treatment. And occasionally those don't fit with NICE guidance. That happened to a certain extent at the start of the IAPT program, and it meant that we were able to look at the outcomes that patients got if they received the NICE recommended treatment or another treatment. And in general, the findings strongly recommended following NICE guidance. So for example, in depression, NICE recommends cognitive behavior therapy and counseling, and we got identical good outcomes with both interventions. For generalized anxiety disorder, NICE only recommends cognitive behavior therapy, but many of my counseling friends would say, but they do pretty well with generalized anxiety disorder. And the data showed they were right. Round about 46% of people who had counseling and generalized anxiety disorder recovered. But what those colleagues didn't know is that if those patients had had CBT, the recovery rate was 58%. So this learning allowed the services to coalesce much more around following NICE recommendations. We then, in a paper published in Lancet in 2018, did some multivariate analyses to see if we could identify some of the features of services that get better overall outcomes. And we found quite a few key points. One was the extent to which the service gave a very thorough assessment and ensured that you got problem descriptors for the particular problems you're going to focus on. Those services that were good at that got better outcomes. Those services that started people's treatment earlier got better outcomes. Those services that managed to keep the sort of DNA rates of attendance down low got better outcomes. Those services where if someone didn't respond to low intensity intervention, fairly promptly stepped them up to high intensity interventions, got better outcomes. And just like with medication, there was a dose response effect. Those services that gave higher average number of sessions tended to get better outcomes. There was another important finding, which was that if you looked at the area that a service was serving, the overall outcomes were less good for those services in more socially deprived areas of the country. And you might think that's a very gloomy sort of finding, because you might feel that's, these are areas where people really need help. But thankfully, this finding, which came out as a sort of univariate predictor, it turned out to be greatly attenuated if you take into account variation in these other, what I call quality features. So once you statistically control for these, then the effect of social deprivation is much, much reduced. So really, the key idea is that if you live in a socially deprived area, it's particularly important that you have a high quality IAPT service. And if that is the case, then you will still do very well with psychological treatments. And this is summarized rather nicely in a local contrast between two clinical commissioning groups, or CGs, that are in a neighboring but are very different in terms of the social deprivation of the population. So one is Windsor, Ascot, and Maidenhead, where the Queen spent much of the pandemic in Windsor Castle. And you won't be surprised to know that's not a very socially deprived area. It's at the 4th percentile nationally. Slough, next door, is one of the most deprived areas in the south of England, and it's at the 68th percentile nationally. However, both CCGs are served by a single high-quality IAPT service with quite a lot of special initiatives for working with more deprived populations. And you can see that both of them have recovery rates above the national expectation and also looking very good on improvement. And if there is any difference at all, it slightly favors Slough. So if the Queen ever felt that she would like to avail herself of the help of an IAPT service, we might almost recommend that she ask the chauffeur to drive her to Slough to have that help. So that's a sort of quick summary of where the program's up to now. I'd like to, because I was also giving you a title of Politics and Economics, to take you back to the beginning and see how the program worked and how it's been progressively expanded. And then I'm going to talk a little bit about its future direction. So in terms of the beginning, the story started in Northern Ireland, and with many good social developments in societies, it started with a tragedy. The tragedy was one of the last, or the last big bombing of the Northern Ireland Troubles in Omagh on the 15th of August, 1998. And you can see there the picture of the devastation caused by a car bomb that killed 29 people, 2 unborn children, and injured 536 people. This was a terrible tragedy, and it was clear there would be many people in the local community who would be haunted by memories of things that they saw that day that no one should ever have to see in life. And there wasn't a lot of local expertise in how to treat those sort of trauma reactions. So the lead psychiatrist, Kate Gillespie here, contacted me and said, would our Oxford team go over and train their clinicians in how to do trauma-focused cognitive behavior therapy for PTSD, which we'd been developing over the years. And that her team was also led by Michael Duffy here. So one of my colleagues, Anne Hackman, and I went over and did the training and supported the clinicians through treating many people through a walk-in clinic, and made sure, because this was a novel situation, that we could try and collect outcome data on everyone. And we never knew whether people would come back to the next session because it was just a walk-in clinic. And so we decided to measure how severe people's PTSD and depression was every time they were seen with a session-by-session simple set of questionnaires. That worked well. We did get outcome data on almost everyone. And what we found, and this is shown here, is that people varied quite a lot in the amount of improvement they got, but no one got worse, which is important when you're dealing with processing trauma. And the most common response was 70 or 90% improvement. And overall, the effect size here was as large as we got in sort of university randomized controlled trials. So that really showed us that you can do as well as research studies in large scale routine services. This data was presented to the Northern Ireland Minister at the time, Des Brown, and he provided funding to create what was called the Northern Ireland Centre for Trauma and Transformation, which then delivered this treatment to victims of various troubles-related traumas for the next decade. So I learned from this that if you collect routine outcome data and you're transparent with what you're doing and you train people well, then that data can be persuasive to politicians and can change the provision that we have for mental health. And that was an incredibly important lesson for when we moved to an initiative covering all common mental health problems and in England. So the arguments behind Ayat were, as I mentioned, presented by Richard Layard and I. Initially, there was a brief note sent to Tony Blair, and then he agreed that we could each have 15 minutes to give a presentation in the Cabinet Office in 2005. Thankfully, that presentation was seen as persuasive, and so Labour put a commitment to increasing access to psychological therapies in its 2005 general election manifesto. They were re-elected and immediately slightly backtracked on that commitment, saying this is a very big program. Let's get a couple of pilot sites and see whether it can really do as well as you say it will, David and Richard. So they funded 2 pilot sites, which ran for a couple of years. Thankfully, they did get the sort of results that were being promised, but we also felt that perhaps a little extra encouragement was needed for the government. So we wrote 2 pamphlets in 2006, one an academic one from LSE called the Depression Report, which put into the public domain the arguments that we given to the Cabinet Office. But also we worked with the mental health charities, and they put out a similar document saying that we want this, called We Need to Talk. And so that really got the national program going, launched with an announcement in 2007 by Alan Johnson, the Minister at the time, saying we will start a groundbreaking new service for mental health. Waits will be reduced to just a few weeks, and at least 50% will recover. So he took the prediction, much to the consternation of some of the civil servants. The program was advancing well when we came to the run-up to the next election, but of course, you never quite know whether things will continue if a government changes. So Richard Layard and I met with the people writing all the party manifestos, outlined why it's important to expand the program, and thankfully they all did make a commitment in their manifestos. Then when the new government came in a coalition, Nick Clegg and David Cameron, they decided, in line with their manifestos, to expand the program more. So Richard and I started working on the next election, and we felt that as well as expanding the program more, it ought to focus on a group of people who often don't get good help, people who've got long-term physical health conditions such as diabetes, cardiovascular disease, as well as mental health problems. And we propose a way of bringing their care together, their physical and mental health care. And that should hopefully be something that any party would want to support in the next parliamentary phase. And to really push that argument further, Andrew Marr interviewed the two of us in 2014 in a public event to which many people writing manifestos were invited. The new government that came in 2015 under David Cameron agreed to the proposal because it had put it in its manifesto. Here, Richard and I are just reminding him of this agreement by giving him a copy of Thrive, which was written in preparation for that election. And you can see that the next two administrations have both chosen, under Theresa May and Boris Johnson, to further expand the programme. So that's really how everything was going pre-pandemic. But then this nasty thing came about, and Ayat was not included in any pandemic plans. It wasn't anyone's pandemic readiness plan. But it was very clear that Ayat was dealing with the most common mental health problems, and therefore the ones which were going to increase to the greatest extent in the context of the pandemic, if there was to be an increase. And so it was clear that Ayat needed to stay open, but people weren't going to be able to come into clinics for treatment. And so it was decided that we would move all the treatment to remote treatment delivery from therapists' homes, give them lots and lots of laptops, and get them to be able to deliver therapy by Teams or other video links or phone remotely from their home. We knew we would have to manage to continue to get outcome data to see whether it had worked. And so we very quickly adapted the IT systems so that you could data entry on your mobile phone. And that worked well. We continued to get data on 98% of all treated patients. The Oxford Centre for Trauma and Transformation, part of the department, helped quite a lot in providing training to the therapists in how to do remote delivery of the therapies, because it was something we'd been doing research on. And that was done by large-scale webinars. Up to 1,900 people attended at any one time. Paul Salkovskis, the chair here, was also giving some of those webinars. And if you look on the OxCADAT Resources website, you'll see some of the other materials that were developed. When you look at the data, thankfully, the outcomes were maintained. So we got just as high recovery rates throughout the pandemic as we did pre-pandemic, and just as many people were treated as they had been beforehand. And this, more than anything else, is a testament to the magnificent Ayat workforce, who worked incredibly hard in very difficult times, and were not the bit of the NHS that was sung about on the front pages of the newspapers, but should have been. And it's perhaps another illustration of how mental health gets much less attention in society than it should do. So, of course, the treatment delivery had to change, and this shows you how it changed. So here you have the blue bars, which is the percentage of sessions that were face-to-face therapy, which was about 2/3 pre-pandemic. But once the pandemic hit, we shifted. So very little was face-to-face therapy. The biggest development of all was actually video therapy, which was pretty rare at the start, but now is actually about 25% of all therapy sessions. There was also something of an expansion of telephone work, particularly for the low-intensity guided self-help parts of the program. So we've learned a lot from this. We've learned that we can deliver these therapies very effectively remotely, and that has some advantages for patients. They don't all have to come into a clinic, and quite a lot of people like that. It also allows much more flexible working for therapists, including more evening sessions being delivered. But it is so for that reason, it's clear that video delivered therapy will be a more prominent part of the NHS in the future. But it is equally clear that we do need to return to offering everyone the possibility of face-to-face therapy. From a patient point of view, a remote therapy doesn't work for everyone. Some people refused it at the start of the pandemic, partly because they didn't have a suitable, safe place at home to have confidential sessions. And also some people really just prefer meeting someone in person. The therapists in the services also missed out to some extent by remote delivery. They missed out on a lot of support from their colleagues. They missed out on the sort of social interactions around a coffee machine, sharing ideas about how to help a patient. And clinical supervision and governance was more difficult. So going forward, the NHS will offer people the choice of remote or face-to-face therapy, but it has to be a genuine choice. And in order to make that definitely the case, we will be monitoring and publishing data on how long it takes before you start treatment if you opt for face-to-face therapy versus remote therapy. And services will be required to ensure that people can start face-to-face therapy just as quickly as remote therapy. So that's one bit of digital delivery. Another bit of digital delivery actually is something that many of you will be aware about, the internet therapies. These are therapies where the key skills, particularly in CBT, are presented in online modules that patients can access from home 24 hours a day. In the programs that work best, they still have a therapist that supports them, but it's remote support, often by messaging within the program or short video or phone calls. And the research on these interventions shows that some of them, not all of them, can be as effective as face-to-face delivery while saving an awful lot of therapist time. And here you see the sort of login page to our internet version of the NICE recommended treatment for social anxiety disorder, form of cognitive therapy. And this is a recent randomized controlled trial where people either had no treatment or were allocated to the internet version of the treatment or the face-to-face one. And you can see the internet version and the face-to-face do really more or less the same, but the internet treatment takes much less therapist time, only about 6.5 hours rather than 20 hours. And this obviously raises the possibility that more people can be treated. The other key advantage of internet therapies is, of course, once you get the content of the therapy right, then the program always delivers that content. Whereas, of course, we as therapists often have good days and bad days, and sometimes we may be delivering better content than others. So this might suggest that you might get more consistency across settings with internet delivered therapy. And we've got some preliminary evidence for that. So in that Oxford RCT that we talked about for the social anxiety, we found 63% of people with internet treatment were fully recovered at the end of therapy, and 84% were markedly improved. We have just been deploying this program in 7 IAPT services around the country, and we found 60% recovery and 81% reliably improved. So it does seem you can go from the research setting to the routine implementation without any marked loss of effectiveness. So a little bit more about present and future developments. I mentioned that in the run-up to the 2015 election, Richard Layard and I were lobbying all of the parties to create a form of integrated physical and mental health care that we call the Ayat long-term conditions program. So that was really responding to the fact that 40% of people in the community with depression or anxiety also have a long-term physical health problem, particularly diabetes, chronic obstructive pulmonary disease, and cardiovascular problems. And this is doubly handicapping, but the way the NHS has traditionally dealt with these difficulties is to give you separate appointments for your mental and physical health care, usually in separate places. And if you manage to get to both appointments, the one thing you could guarantee is that the people who are looking after your physical health care would not be talking to the people looking after your mental health care. This is silly. It doesn't make any sense at all. And so the aim of the IAPT program was really to integrate physical and mental health care. There was some pilot work done, particularly in the Thames Valley region by Oxford-related services, bringing together physical and mental health care for diabetes and cardiovascular disease. and some good pathways were developed. There was good research evidence that Richard Layard and I mastered to show that it should save money for the NHS. And so a phased national rollout of these services was started in 2018. It's not finished, but we've got about 75% of CCGs now having IAPT long-term conditions services. And although people with long-term conditions are really doubly handicapped, you can see that the overall improvements in mental health are very similar between the two groups, which is most encouraging. But we've also been collecting data on the economic argument that underpins this. You know, is it really the case that by bringing together your physical and mental health care, we can save the NHS money? That's a very important consideration for rolling out any new initiative. And the answer seems to be yes. So in a study again that we did recently in the Thames Valley, we used what we call a step wedge design. We rolled out the IAPT LTC service in some CCGs ahead of the other CCGs, and the late rollouts were the control group. And what we found is that secondary healthcare costs, so admissions to hospital and outpatient appointments for physical healthcare, were reduced by £360 per patient in the first 3 months where we deployed the IAPT LTC services. And also we found that as we were helping people manage their mental health problem and their long-term condition together, that helped people get back into work if they're unemployed. So there was a sort of relative improvement of 9 percentage points in employment. This week, a new study has also been published looking at all the national data, and that shows that IAPT treatment for people with anxiety and depression in the context of COPD, diabetes, and cardiovascular disease substantially reduces the later probability of a hospital admission, again, producing very substantial savings. Thankfully, all of this was in place before long COVID came along. And so now the IAPT LTC services are starting to help people with long COVID, not with any idea that the symptoms that people experience with long COVID are in their head. They're not, they're very real symptoms. But of course, many people will also become depressed and anxious in the context of those physical symptoms, and we can help a lot with that. So that was really a bit about outcomes. So do you think we've got as far as we could go, or do we think we can go a bit further? Well, if you look at this graph, you might say, well, we're maybe plateauing here. We definitely have got pretty much a plateau the last 6 years, haven't we? And we've achieved our target of 50%. So, you know, maybe that's it. I don't think it is. We have every month some services that are getting recovery rates of nearer 60%. And we also have some new data which suggests we can go further. So here, this is a histogram looking at the last 1 million people who had a course of treatment in IAPT, and it looks at how many sessions they had before they were discharged. The current average number of sessions is almost 8, and you can see the strong clustering in these lower numbers here, but also some people having sessions up to 20 or 30. So the question is, if you don't recover, say after 8 sessions, and we give you a few more sessions, what's your chance of recovering? Is it worth us doing that, or have we got to the sort of sweet spot and extra therapy won't help? Well, the answer is we haven't got to the sweet spot. It does look as though extra therapy would help. This graph here shows the recovery rates and the reliable improvement rates as a function of how many sessions people had before discharge. So people tend to be discharged once they've recovered. So the people up here are the people who didn't recover with a smaller number of sessions. But you can see that even extending up to 20 or so, we're still getting above our target recovery rate. And we only get to a point of no further benefit when you're up to 30 sessions. So at the moment, we're currently lobbying to be able to further increase the average number of sessions that IAPT services are able to offer. Of course, all of these things are only possible because Ayat does collect outcome data on everyone, and we can learn from that data. So the last point I'd really like to make in this talk is that that isn't universally the case in the NHS. In fact, in most mental health sectors, we don't currently record and publish outcomes. This must change. Under the NHS long-term plan, we're putting an extra £1 billion a year into community mental health services. But in those services, there is no nationally agreed set of outcome measures. So that obviously they're not mandatory. Hardly any outcome measures are collected, and no outcome data is published. So all the benefits that you've just seen from having data and learning from it simply cannot happen in community mental health care services. That's also true in most other sectors of mental health. In early intervention services for psychosis, we are in a good position that we've got a nationally agreed set of measures, and they are notionally mandatory, but less than 50% of patients actually get to fill them in, and no one is publishing what the data tells you. The same is true in children and young people's mental health services, and the worst position still in liaison psychiatry. But there is an islet of hope in the new schools initiatives for mental health. We do, just like in IAPT, have an agreed set of outcome measures. They are mandatory, and although it hasn't quite got to the IAPT level of data completeness yet, it's up to 72%, and the outcomes are being published so we can learn from it. So to wind up, IAPT, I think, is generally considered to be a successful program, but it isn't finished, and it can go further, and it can be improved much more. But it has got a very good press around the world, and it has been widely copied in Norway, in Israel, in Australia, in New Zealand, Finland, and Ontario are all creating their own IAPT programs. And to help them do that, we've brought out some slightly different versions of Thrive. The one for the American market says quite simply, Thrive, how better mental health care transforms lives and saves money. The Dutch version has as its title Therapy Winst, which I'm told means therapy profit, but it's rather subtle because it means both personal benefit but also economic benefit. So thank you all for listening.
Thank you, David. So David's kindly allowed some time for questions.
So you were talking about evidence-based therapies, and I wanted to quickly ask which ones are being featured. Like, is it CBT and DBT, or which ones is it specifically looking at?
So the aim of IAPT is to implement whatever NICE recommends for the conditions that it's for, which is depression and all the anxiety disorders. So, you know, generalized anxiety, agoraphobia, social anxiety disorder, health anxiety, post-traumatic stress disorder, obsessive compulsive disorder. So in the current NICE guidelines for those anxiety disorders, it's various specialized forms of cognitive behavior therapy that are recommended. For depression, it's quite a range of interventions which are recommended, and at a similar level of strength of evidence. So we have cognitive behavior therapy, but we also have a treatment called interpersonal psychotherapy. We also have brief psychodynamic therapy, particularly a model developed by Peter Fonagy and his colleagues at University College London. And we also have a particular form of counseling and also couples therapy. And there are, in every area of the country, there are some people who are depressed in the context of a relationship issue, but they have a partner who still wants to give it a go and would like to participate in therapy if it could be helpful. And so we feel it's really incredibly important that every IAPT service offers that as part of its offer. At the moment, I think an audit showed that 93% of all IAPT services offer people a choice of different therapies for depression. The most common choice is between CBT or counseling. But we have some services, but it's a minority, that are offering up to 5 different interventions. There's one other intervention which has now come into play, which is mindfulness based cognitive therapy. That's because NICE recommends it as a way of reducing relapse, particularly for people who've initially had medication as their treatment. And there are a number of people who come into IAPT who fall into that group, and so they are also offered the mindfulness-based interventions. And as NICE guidance evolves, IAPT will also evolve. It's defined as offering NICE guidance.
Okay. Thank you.
Thank you.
I'm going to take one from the text and then Gaia. So from the text box, you're thanked for your talk, David. When adapting therapy for long-term conditions, what training do you think therapists need about the specific condition to effectively deliver therapies, that is, in the light of the limitations that might be imposed by the particular condition on the therapy process?
Yeah, so there's quite a lot of information that people need to know about the particular conditions and their management and the limitations they place on people's lives. It's also the case that we have learned from the pilots that there are some better ways of delivering the therapies than others. So, for example, for group treatment for depression, we found that if you have people with depression and diabetes, although they do well in a general depression group, their diabetic control doesn't improve. But if you create groups which are entirely for people with depression and diabetes, we get improvements in diabetic control as well. So the IAPT workforce, we've developed a sort of continuing professional development training program, which really trains up those people who will work with people with long-term conditions in information about the nature of those conditions and about the adaptations for therapy that seem to work best.
Thank you. So Gaia.
Thank you. Thank you, David. Really enjoyable as ever. I wondered whether you could tell us what you think are the biggest challenges and the biggest opportunities of adapting IAPT for younger people, and also for people with different language and or cognitive skills who are younger. And by that, I mean younger people with intellectual disability or language and communication difficulties. Challenges and opportunities in the NHS. Yeah,
okay. So, I mean, what seemed to not work very well is to just try and expand the capacity of CAMS services. CAMS services are quite overstretched, and they tend to see people more in a crisis. Otherwise, the waits are very long. So the first attempt was to bring in some IAPT type workers, but specializing with young people into CAMS. And I don't think that really created a big change. And also the CAMS still has a very low rate of recording outcomes. So as you probably know, the next initiative, which is working much better, is the New Schools initiative, where you put particularly the children's version of the low intensity workers in schools or near schools, and people can have treatment not just because they're in a crisis, but as soon as it's appropriate. And there's also an attempt to somewhat change the culture within schools to make people more focused on well-being and mental health issues in general. And I think that is progressing well, but it's at early stages. So I think by the end of this Parliament, it's meant to reach 40% of schools. And as you saw from the slide, it is now using essentially the same principles that we used in IAPT for data collection, session by session measurement, a good simple IT system to support and things. It is getting data on most of the young people going through. Of course, you were asking the question, well, what about, well, firstly, 40% is nice, but it's not where you need to get to. You need that in all schools, so that needs to be expanded. I'm hopeful that it will be, because unlike anywhere else in mental health, it's collecting data. And what I've learned is that if you collect data and you show the politicians that, and you show you invested, and IAPT is £680 million a year, you invested £680 million, this is what you got, and it's what you expected, or in fact, it's a bit better than you expected, then it's easy for the Treasury to say, well, we want to support it further, particularly when there are big savings. So I'm hopeful that the way the schools initiative is going, it will expand further. But then there's the issue about, well, what about neurodiverse populations and things like that? And I think a lot of that depends on having gifted clinicians in the service, because I think what you need is people who will try out some of the existing treatments in a systematic way with people with ADHD or autism and things like that, and work out in a collaborative team way, often with networks, how you can sort of refine those interventions or deliver them slightly differently in a way which works much better for those populations. And as long as you're keeping the data on everyone, you can see what works and what doesn't. And so I think, you know, we're in a position where there is a good foundation potentially for doing that work, but the work needs to be done. Does that make sense?
Thank you. Toby in the chat box has said, have any other countries successfully implemented IAPT or similar programs? I know you briefly alluded to this earlier.
Yeah, so the biggest implementation is in Norway, which now has 60 IAPT services, which cover almost the whole of the country. And they are also publishing their outcome data, and it's very similar to ours. Another one which is very closely modeled on the UK is the Canadian province of Ontario, which has launched what it calls its structured psychotherapy program, but it's very similar to IAPT, and it has set up a national data repository which will do the sort of month-by-month analyses and learn from it. And I think I advised the ministers and other people in both those countries, and I think to the Canadians, the thing that they found most impressive from IAPT was the data collection and learning from it, and so they've really invested in getting that in place next time around. Israel has a national pilot running at the moment, and Australia has a program called New Access, which is modeled on IAPT.
Good. Peter Nash. Peter, muted.
Yeah, just unmuted. Thank you.
Hi, Peter.
Hello, David. Good to see you after so long. And a lovely talk, of course. This sort of builds on an earlier question, I guess. But can you see any sort of characteristic of the person who isn't, even after 20 sessions, going to get very far? Presumably, if you could do that unerringly, then you would straight away save money by sending them down a different route.
Yes. So the answer is, when you've got these large data sets, you can. Some work is going on with that at the moment. I collaborate with a team at UCL that now has access to the whole IAPT data set, and we're looking at those predictors. And one of the key predictors used a latent profile analysis, and we've identified what in the technical language isn't very helpful, is latent profile 7. So this is a subgroup of people. It's about 9% of people seen in IAPT services who actually get very poor outcomes from the services. They're about 20% recovery. You won't be surprised to hear, are very severe in terms of their anxiety and depression. They also tend to be in receipt of benefits, and also, and this is a surprise to everyone, they score very high on the phobia measures. So we've now got a project going in the Thames Valley IAPT network, which I run, where we're identifying these people prospectively when they come into the service, and we're giving them an enhanced access, firstly to employment advisors to help them get back into work, and also looking at helping them with their phobias. And the preliminary data is very encouraging. We seem to be getting change in recovery rate from around about the 20% that you get in the sort of naturalistic observational cohort to nearer 38% when I last saw the data. So a doubling of those outcomes. So again, this is why getting the data matters so much, and why, as far as I'm concerned, it's a total scandal that we don't have it in the rest of mental health.
Thank you, Peter. David, last question from Kate Costello. What advice would you give services to increase collection of complete outcome data?
Oh, I see. So, I mean, in IAPT services, it's not a problem because we get it on 99% of people. But how did we achieve it?
Well, I think it's what advice you would give to services which are not IAPT services, I guess, like the ones you listed, I think. But yeah. Kate, I mean, if you're there, you could always clarify. Don't worry, carry on.
Yes, that's what I meant on services that are not IAPT services that might be struggling to collect as high rates of data as IAPT.
Yes, so because this is sort of the last question, what I should probably say is that I think it's right in saying that on our website, we have a sort of 10-minute video talk that I gave to the Psychological Professions Network on what you need to put in place to get these high levels of data completeness across mental health. And I should refer you to that. But briefly, you need to measure it every session because people drop out of therapy when you don't expect it to, so you don't get the data unless you measure it every session. You need to make sure that the measurement is not a burden to the clinicians. So phone entry into the data is good rather than having to type in responses people do to paper questionnaires. You need to make sure that you train your clinicians to use the outcome data to guide what they do in therapy so that patients can see it's helpful and makes sense. And you also need to move to reporting that data early on rather than late on. So I think in NHS managers' minds, they often feel, well, we won't report the data until it looks good. But if you take that principle, it will never look good. It's really important to start publishing early. And I would recommend using what we call SMART metrics for that. So these are ones which provide no incentive to a service to not collect the data. So for example, if you treated 100 people and you got data on half of them, so 500, and half of those people recovered, so 250, instead of saying the recovery rate for that service is 50%, so half the people that you collected data, you say the recovery rate and you publish that the recovery rate is 25%. That is the principle that we've used throughout IAPT reporting since 2005. And services rapidly discover there is no point whatsoever in failing to collect the data.
Okay, well, thank you very much, David. I suggest everyone unmutes and gives David a round of applause. So unmute now, guys, and hooray for David.
Thank you, Paul.
Thank you, David.
Cheers.
Have a nice day, everyone.